Good morning, students. Today is the applied physiology of hearing, today's class. Now this class is the last class on this hearing. Okay, so you have done all the physiology of external, middle, inner ear, the neurophysiology of hearing, okay, and the physics of sound. You have done all this. Now today we will deal with the applied physiology of hearing. Now in applied physiology for you undergraduate, the first year students, most important is the deafness, okay, and this deafness is also, this today's topic is also very important practical wise, okay. This class is important for practical, not that much important for theory, okay. Now, so deafness is inability to hear, okay, it is inability to hear, you can say damage in hearing pathway, and there are two types of deafness. One is conductive deafness, another is sensory neural deafness, okay. Conductive deafness means when problem is in the external plus or middle ear, and sensory neural means when the problem is in inner or the nerve pathway, okay. So these are the two types of problem. Conductive, that means problem in conduction of the vibration, and sensory neural. So here either the sensory receptor cells or the nerve pathway problem, okay. So first, conductive deafness. Now conductive deafness refers to impaired sound transmission in the external or middle ear, and it impacts all sound frequencies. All sound frequencies will be affected here, okay. Now what are the causes of conductive deafness? First and very common cause, also very common cause in children, wax accumulation, cerumen deposition. So that will lead to conductive deafness, okay. Then foreign body, it will lead to conductive deafness, okay. Next, otitis externa. Otitis is itis means inflammation, and externa. So inflammation of the external ear is otitis externa. It is also known as swimmer's ear. Why? Because say most common in villages nowadays, say in villages the pond where the villagers take bath, it may be dirty. পন্ডটা যদি পরিষ্কার না থাকে তাহলে if the villagers take bath, then what happens? There is infection to the external ear. That is known as otitis externa, and that is why it is also known as swimmer's ear. Then otitis media. It is problem because otitis, that means inflammation of the middle ear. So inflammation, so that means that there is fluid accumulation in the middle ear, and ultimately if kept untreated, that will lead to perforation of the eardrum, okay, that will lead to perforation of the tympanic membrane. Now another is otosclerosis, in which the bone is resorbed and replaced with sclerotic bone that grows over the oval window, okay. So now the stapes becomes a bit fixed with the oval window, that leads to problem in conduction, okay. Then this is about conductive deafness. Now sensory neural deafness, I told you that the problem lies either in the sensory hair cells or with the nerve pathway. So first is, say there is cochlear hair cell damage, loss of cochlear hair cell, okay. Second, there may be tumor in the 8th cranial nerve and CP angle tumor, cerebellopontine angle tumor, okay. That will lead to also deafness, which is sensory neural, okay. Then there may be vascular damage in the medulla that lies in the pathway, hearing pathway. Then there is some antibiotics like streptomycin, gentamicin, that damages the stereocilia of hair cell, the mechanosensitive channel present in the stereocilia, that tip link and the channels, it damages that channel, okay, and that will cause the hair cells to degenerate, producing sensory neural deafness. Okay. Next is there may be damage to the hair cell by prolonged exposure to noise. Okay. That I have told you in my last class. If say there is prolonged exposure to noise, there will be the loss of hair cell, damage to hair cell, and also say very high, loud, very loud sound. That will also lead to the damage or loss of the hair cells. Okay. Now, in this sensory neural deafness, it often impairs the ability to hear certain pitches, while other pitches remain unaffected. Okay. In conductive, all the pitches are affected like same, but here some are affected more than others. Okay. Now, and the auditory acuity, that is the whether there is deafness present or not, that is done by this audiometry. Okay. Now you don't have to go with the detail of audiometry, because that you will learn in your ENT during your ENT time. Just today for first year you remember the name. Okay. With audiometer we measure the auditory acuity, graphical representation. Now what is important is for you practical purpose, how to differentiate between conductive deafness and sensory neural deafness. You have to differentiate it. Whenever you are given eighth cranial nerve testing, you will you know about the two tests, Rinne's test, Weber's test, and you have to show Rinne's test, Weber's test, and then examiner will ask how you will differentiate between conductive and sensory neural deafness with the help of Rinne and Weber. Now you know about the Rinne's test and Weber's test. In Rinne's test, what you do, we take a tuning fork, we vibrate it, and we put the vibrating tuning fork over the mastoid process. Okay, and we feel the vibration. When the vibration stops, the subject says it has stopped. Then quickly you take the tuning fork and you put it near the external canal. The subject says, yes, I hear sound. That means when you are putting it near external canal, that means you are measuring, you are looking for air conduction. And when you are putting in the mastoid process, you are going for bone conduction. So normally the air conduction will be more than bone conduction. That is Rinne's positive. Okay. Now, in case of conductive deafness, what will happen? Air conduction is hampered. The conduction part is hampered. So, in conductive deafness, it is Rinne's negative. Here, bone conduction is more than air conduction. Now, what about sensory neural deafness? In sensory neural deafness, it will be Rinne positive. Air conduction is more than bone conduction, but intensity is diminished. Okay, intensity is diminished from normal. Okay, so this is about Rinne's test for conductive and sensory neural deafness. Now you will go for Weber's test. In Weber's test, what you do, you take the vibrating tuning fork and you will put it in over your forehead, over the patient's forehead, and you will ask that whether you are hearing the vibration in centrally or you are hearing it to more towards one ear. Okay. If the subject is normal, then he or she will tell that I am hearing it centrally, or it is equally distributed, or it is present centrally. Okay. That is Weber's test is normal. Now what will happen to conductive deafness? In conductive deafness, so here noise from outside is entering less in the diseased ear. Okay. So what will happen here? When you are putting the tuning fork over this forehead, then the subject will hear more towards the diseased ear. So the patient will tell the sound is more towards, say if my conductive deafness is in my left ear, then the patient will tell that I will tell that it is going towards the left ear. Why? Because as there is no sound coming from external ear, so masking effect is not there. Okay, masking effect is not there, but in this ear there is masking effect, you know this. That is why in the diseased ear the subject will hear more. Now what will happen in sensory neural deafness? In sensory neural deafness, the subject will tell that the Weber is lateralized towards the normal ear. Okay, because due to sensory neural deafness, to the diseased ear there will be no conduction. So here now the subject will tell that it is localized towards the normal ear. This is how, by doing Rini and Weber, we can differentiate between conductive and sensory neural deafness. So it is said that method, base of vibrating tuning fork is placed over vertex of skull or forehead. We go for forehead. Okay. Now normally the subject will hear equally on both sides or centrally. He will tell it is centrally located. Now in conduction deafness, sound will be louder in diseased ear because the masking effect of environmental noise is absent in diseased ear. That is why sound will be louder in diseased ear. But what will happen to sensory neural deafness? In sensory neural deafness, sound is louder in normal ear. So now it will be localized towards a normal ear. Okay, this is about the Weber's test. Now Rini's test. In Rini's test, what is the procedure? The base of the vibrating tuning fork is placed over the mastoid process of the subject, and when the subject no longer hears it, then held in air next to ear to see air conduction. What will be the normal finding? Normally, hears vibration, the subject will hear vibration in air after bone conduction is over. So normally air conduction is more than bone conduction. Okay. Now what will happen to conductive deafness? In conductive deafness, there is problem in conduction. So here the vibration in air is not heard after bone conduction is over. So here what will happen? Bone conduction is more than air conduction. And in sensory neural deafness, what will happen? The vibration will be heard in air after bone conduction is over, as long as nerve deafness is partial. So when nerve deafness is partial, air conduction is more than bone conduction, but intensity decreased. Okay, so this is how you have to tell in the exam how to differentiate between the conductive and sensory neural deafness with the help of Weber's and Rini's test. Okay, this is all about this conductive and sensory neural deafness, and in last part, a very small part, is presbycusis. Here there is gradual hearing loss associated with aging. With age there is hearing loss. It affects more than 1/3 of those over 75, and it is due to gradual cumulative loss of hair cells and neurons. So with age we lose the hair cells, that will lead to hearing loss. Okay, so this is about today's class. This class is very important practical wise. You have to know the two types of deafness and how to distinguish between the two types of deafness with two tests, Weber's test and Rini's test. Okay, thank you.